Left atrial plication is done by the surgeon, and post plication you can see that the LV contours become normal. So here it is 50, and that means that it is likely to develop, she is likely to develop atrial fibrillation at any time. Now coming to the classification of the pulmonary artery hypertension, it is considered as mild when the mean pressure is 20 to 30, moderate 31 to 49, and above 50. In this case, in our patient, it is above 70. That means it is a severe pulmonary hypertension. Then coming to the pulmonary venous hypertension, mild, moderate and severe are very important. Now assessment has to be, one thing you must remember, the patient has got PND. Unless the patient has got orthopnea, it is not considered as the class 4, and hence this patient is in class 3. And these are the precipitating factors. In the history, you must take all these parameters and then come to the conclusion. In our country, recrudescence and anemia are very common. Then tricuspid regurgitation is almost 70 to 85% of the time it is a functional one, that is secondary to the pulmonary hypertension. But in the remaining, if it is the organic one, then we have to tackle the valve. So tricuspid regurgitation, calculation in the apical 4-chamber view and also in the CW Doppler and the Vena Contracta, and apart from that, grading differs in the tricuspid regurgitation. We have mild, moderate, severe, massive and torrential. So whenever there is a severe, massive, torrential, surgical options are important, or they can be transcatheter valve clip, mitral, tricuspid valve clipping can be done if the patient can afford. So here it is very important that grading of the tricuspid valve and all severe TR has to be fixed. That is a dictum. If you don't fix the tricuspid valve and do the balloon dilatation or do whatever the surgical options for the mitral or the aortic valve, and all that becomes waste, the patient goes into congestive cardiac failure, and hence the normal tricuspid valve annulus is 31. Without treatment of the severe TR, it carries poor prognosis. So severe TR, it has been observed that 100% mortality in normotensive TR, and as a result the moral apply combos criteria, and if tenting of the height is more than 10 millimeter, plain annuloplasty can be done. So these are the options, surgically or non-surgically. We have the tri-clip which is available. If patient can afford the cost, they can go for the transcatheter tri-clip replacement, and transcatheter annular, and apart from that we have a direct suture annuloplasty which reduces the annulus. We have a direct ring annuloplasty where a ring is put, and the coaptation enhancement can be done surgically, and the valve replacement is the last option. So in this patient, the surgeon can take a call whether it is a direct suture annuloplasty or the ring has to be put for the tricuspid valve. If you look at the natural history of the TR, whenever the annulus becomes dilated, the patient has to be treated. So in our case, first option is balloon dilatation, that is PTMC, plus transcatheter valve replacement. If the patient cannot afford the cost, then OMP with the aortic valve repair and the tricuspid valve annuloplasty, and LA plication if the patient is likely to develop the ARP. So we have two options, surgical and non-surgical. In non-surgical, we have the balloon dilatation and the tri-clip for the tricuspid valve, and then the surgical option, all the three valves can be repaired by the surgeon. So here outcomes in our own hospital, we have 1686 repairs were done in 18 years, and 5 replacements were done later on for the endocarditis. Most of them they did very well, and this is published in the book. So friends, echo plays a major role in prevention, treatment as well as the prevention of the complications. So to conquer the rheumatic heart disease, we have to use the echo criteria and be specific about what we do. So echocardiography is the key technique used to confirm the diagnosis of the valve lesion. All quantification methods to assess severity of the valvular lesions have limitations. They combine a number of measurements, therefore their use requires experience and integration of the number of measurements rather than the reliance on the single parameter. So take-home measures are diagnosis of the severity with the valve lesion by clinical examination is very important. Do not rely upon a one parameter. Specify assessment of the mitral, mild or the significant lesion. Echocardiography and the Doppler evaluation is a gold standard. Has clinical examination just been relegated to the screening tool? No. Clinical acumen and echo should go as a hand and glove, and as far as I am concerned, without clinical acumen, going for the echocardiography evaluation is not correct. And hence, I would like to conclude saying that children may be victims of fate, let them not be victim of our neglect. Rely upon the clinical acumen as well as the assessment of the echocardiography, and that's how the whole acute rheumatic fever, chronic rheumatic heart disease, this is the second edition, and it has everything and 3 chapters especially on the echocardiography. Thank you very much for your kind and patient hearing. Thank you.